Assalamu alaikum. Let's talk about a very important topic called systemic sclerosis, also known as scleroderma. We know that systemic sclerosis is a chronic, it's a chronic autoimmune disease. It's a chronic autoimmune disease of unknown etiology characterized by increased fibroblast. There is increased fibroblast activity and fibrosis in a number of the different organs in the form of hardened sclerotic skin and other connective tissue. We know that scleroderma or systemic sclerosis four times more common in female than the male. There are multiple patterns of these diseases, but three patterns is very important. It is limited cutaneous systemic sclerosis, limited cutaneous systemic sclerosis, where Raynaud's is the first sign. Raynaud's is the first sign. Raynaud's is the first sign. And in scleroderma and Raynaud's phenomenon may be associated with ischemic and traumatic digital ulceration and digital ischemia. There may be traumatic ulcer over the PIP joint. There may be ischemic digital steep ulceration secondary to small arterial disease. And there in scleroderma affects face, distal limbs predominantly face, looks like fish mouth appearance, face and distal limbs. In the face there is perioral skin tightening, perioral skin tightening with decreased oral aperture and furrowing around the lips and dry mucous membrane. Periodontal disease with the regression of the gum and loosening of the teeth, and there may be telangiectasia on the lips and the tongue. There may be telangiectasia on the lips and the tongue. It is associated with anti-centromere antibody. So anti-centromere antibody looks like Raynaud's, and that there is a mnemonic called Crest syndrome. It is also called Crest syndrome. Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. There may be telangiectasia. Calcinosis cutis. There will be calcinosis cutis. Calcinosis cutis, if we do an X-ray of the hand, in AP view of the X-ray of the hand, this scleroderma shows extensive calcification. There may be extensive calcification involving the soft tissue of the distal phalanx. Complication of the Crest syndrome, malabsorption can develop in patients secondary to bacterial overgrowth of the sclerosed small intestine. This modality is secondary to infiltration of the intestinal wall with fibrosis. There may be in most important thing in limited variety. It is limited. Pulmonary hypertension can happen. Pulmonary hypertension is one of the more late complication in such a patient. So malabsorption and pulmonary hypertension. We know that it is very difficult to distinguish between ILD, interstitial lung disease, and pulmonary hypertension as the cause of the breathless and systemic sclerosis. We know that lung involvement is a frequent complication of the systemic sclerosis and can be split to main syndrome, a pulmonary vascular disorder evolving over time relatively to pulmonary hypertension and interstitial lung disease. So pulmonary hypertension happen in a limited variety of systemic sclerosis, and there is diffuse variety, diffuse systemic sclerosis, diffuse anti-SCL70, anti-SCL70 antibodies positive. Scleroderma affects the trunks and the proximal limb predominantly. In diffuse variety trunks and the proximal limb, there will be hypertension, lung fibrosis, renal involvement may be seen, and poor prognosis. There is poor prognosis. Whilst diffuse systemic sclerosis is associated with more severe and rapid internal organ involvement and is also seen in the limited form. And morphia, localized scleroderma without internal organ involvement, there may be tightening and fibrosis of the skin. There may be tightening and fibrosis of the skin. Diffusely puffy fingers are a common initial presentation. Diffusely puffy fingers are a common skin presentation. There may be shiny skin, suggests impending skin thickening. Shiny skin, suggesting of a skin thickening. May be manifest as plaques, morphia, or linear. This is well defined oval to round plaque like a painless lesion to his left, a subcostal region dry, indurated, and slightly coarse to palpitation. So, in systemic sclerosis, there may be diffuse hyperpigmentation and depigmentation with sparing of the peripheral skin, resulting in salt and pepper appearance of the leg skin in patient with systemic sclerosis. The, in morphia variety, in here, an autoimmune component is suggested by enhanced T helper 2 dependent interleukin 4 activity, which in turn regulates transforming growth factor beta. TGF beta stimulates fibroblast production and collagen, the fibroblast production of collagen and other extracellular matrix protein. In lab, elevated DSR and CRP, there may be hypergamma-globulinemia, increased IgM or IgG, peripheral eosinophilia, elevated DSR, CRP, hypergamma-globulinemia, peripheral eosinophilia, and mm, anti-copper zinc peroxide dismutase antibody. Anti-copper zinc superoxide dismutase antibody may have been found up to 90%. A major complication is the development of scleroderma renal crisis, which is characterized by abrupt onset of severe hypertension, usually retinopathy, therefore with rapid deterioration of the renal function and the heart failure. If we look at the scleroderma renal crisis, sudden onset hypertension, papilledema, azotemia, MAHA, microangiopathic hemolytic anemia, hematuria, and proteinuria. Treatment is ACE inhibitor. In renal crisis is linked with positive ANA, speckled pattern, very, very, very high yield, positive ANA speckled pattern, positive ANA speckled pattern, anti-RNA polymerase 1 and 2 antibodies, and absence of anti-centromere antibody. So anti-centromere antibody, limited variety, no renal involvement. In systemic variety, in diffuse variety, there is renal involvement. The clinical presentation typically with the symptoms of malignant hypertension, headache, hypertensive retinopathy with a visual disturbance, seizures, heart failure, and pulmonary edema. Renal biopsy is not necessary in patients presenting with classic features of renal crisis. The hypertension is almost always severe with a diastolic blood pressure over 100 milligram in 90% of the patient. There is hypertensive retinopathy uh, in about 85% of the patient with exudates and hemorrhages with exudates and hemorrhages. If there is severe papilledema, there may be MAHA microangiopathy hemolytic anemia. There may be MAHA decreased hemoglobin with decreased hemoglobin with blood film show schistocyte helmet cell fragmented cell schistocyte helmet cell fragmented thrombocytopenia and a raised renin renal function is impaired and usually rapidly deteriorates. So there may be anemia, there may be thrombocytopenia, and increased renin. Sclerorenal crisis is a medical emergency. Aggressive treatment is required to prevent the occurrence. First line is AC inhibitor. Gradual reduction in the blood pressure 10 to 15 milligram 10 to 15 mercury per day with an oral AC inhibitor until the diastolic pressure reaches 85 to 90%. AC inhibitor will improve hypertension, show further renal improvement. AC inhibitor is a choice of systemic sclerosis with renal disease, increased creatinine plus hypertension. So AC inhibitor is a choice of systemic sclerosis with a renal disease, increased creatinine hypertension. These approach leads to response in 90% of the patient, reversing the AC2 mediated vasoconstriction. An abrupt fall in BP should be avoided as it can further diminish perfusion and increase the risk of acute tubular necrosis. Parenteral antihypertensive, I mean labetalol, nitroprusside should be avoided. Calcium channel blocker, nifedipine works good. May be added when there is inadequate reduction of the blood pressure with AC alone. Additional oral hypotensive agent, for example, labetalol, can be used if required and if pulmonary edema is present. A nitrate infusion may be indicated. If there is pulmonary edema, you can use nitrate infusion. There is anecdotal evidence that IV prostacyclin helps the microvascular lesion. IV prostacyclin helps the microvascular lesion without precipitating hypertension. So antibody ANA positive speckled pattern usually. Aromatic factor positive in 30% anti-centimeter antibody for limited variety anti-cell antibody diffuse cutaneous systemic sclerosis lung involvement anti-RNA polymerase 3 antibody diffuse cutaneous systemic sclerosis risk of ILD risk of sclerorenal crisis risk of ILD risk of an anti-E1 RNP may be positive high risk of pulmonary hypertension in limited cutaneous systemic sclerosis anticentromere antibody. We know that the most common cause of death in systemic sclerosis is respiratory involvement, interstitial lung disease, pulmonary hypertension. Management is topical treatment for skin changes do not alter the disease course but may improve pain and ulceration. NSAIDs, steroids, the calcium channel blocker, nifedipine can be used. Bosentan, dual endothelial receptor antagonist, and phosphodiester 5 inhibitor. You can use methotrexate, cyclosporin, and in sclerorenal crisis inhibitor to control blood pressure and delay the progression of chronic renal failure. And in a case of acute alveolitis, pulse cyclophosphamide and a small dose of steroid is given. So in here treatment AC inhibitor And there are other treatment also. You can give steroid. You can give calcium channel blocker, nifedipine. You can use bosentan, ambrisentan, dual endothelin receptor antagonist, or iloprost. Methotrexate cyclophosphamide, limited renal crisis. So that's all about um systemic sclerosis. Hope you